So obviously, the checkpoint inhibitors are a big advance, and in the MSI-high patient, either nivolumab or pembrolizumab are both available. The addition of ipilimumab adds a little bit to the effectiveness of the nivo, but adds a lot to the cost and adds a lot potentially to the toxicity. So it's something we have to be very careful about. You can put a lot of money down to get those combination treatments in with a lot of risk, but the upside is again significant. We tend not to, we at least at our group here at UCSF, we've not been using the combo that much in patients, although patients with high burden disease, we don't think we have a second chance. We are using it. In general, we start with a single agent checkpoint inhibitor and then go from there. But I think it's a new advance, it's a great advance. Again, how we can afford it and all. The real issue is figuring out who's going to benefit and using the drugs in those patients. And then I think the second question is figuring out if patients don't benefit, why, and or if patients benefit for a period of time and then become resistant, figuring that out. That's very important if we're going to expand the reach of these drugs to more patients. Right now, no more than 5% of patients with advanced colorectal cancer are candidates for these drugs, and we have to do better than that. A big study just completed was very disappointing, a study looking at atezolizumab and a MEK inhibitor, cobimetinib, downright negative study and very distressing because we thought there might be some progress there, no progress at all. So we've got a lot of work to do in that arena.
In patients who are mismatch repair deficient or MSI-high, now we have options with immunotherapy. Now you could use a single agent, such as nivolumab or pembrolizumab, or now you could use a combination of combining a checkpoint inhibitor plus a CTLA-4 inhibitor. Now the benefit, there's no head-to-head comparison comparing a single agent checkpoint inhibitor or single agent checkpoint inhibitor plus a CTLA-4 inhibitor. However, if you look at those data, the response rate of doublets seems to be a little bit higher at maybe at 55% compared to a single agent, which can range from 30 to 50%. However, when you start combining this immunotherapy, the toxicity becomes a concern. So if you look at the grade 3-4 adverse event, the doublet seems to be a little bit, the adverse event of doublet seems to be higher than a single agent. Therefore, if the patient who's MSI-high or mismatch repair deficient fail one line of chemotherapy, and if they have low burden of disease, they're asymptomatic, I would tend to go with single checkpoint inhibitors. However, if they're symptomatic or if the tumor is bulky and I'm trying to induce response, then this is where I'll probably use the doublets, using nivolumab plus ipilimumab in those settings. Now, we need more data on this, but the combination can also be possibly useful as a first line. Now, obviously, there's no data to support this, but in the future, hopefully the data will come up and that we could use possibly a more aggressive regimen as a first-line therapy in patients who are MSI-high or mismatch repair deficient.
For a long time, we have to remember that nobody thought immuno-oncology was going to ever make it to colon cancer. And a breakthrough study actually demonstrated that pembrolizumab had activity in MSI-high positive colon cancers, actually in any solid tumor that's MSI-high, and got an unbelievable approval across all different diseases based on a molecular biomarker. And then the combination of ipi-nivo was tested in MSI-high colon cancers and actually demonstrated a slightly higher response rate, slightly higher improved outcome. Now, I do think it's important for everybody to remember that a lot of patients who are MSI-high still don't respond to checkpoint inhibitors, whether single agent or combination. I sort of have in my head that if you have this, oh my goodness, it's going to work for sure. Well, the reality is no, it's not. Only about half the patients respond to therapy. So we need better biomarkers, we need better combinations, and it's encouraging to see the ipi-nivo combination moves the bar a little bit, not a lot, but a little bit, in terms of improved response rate and improved outcomes. And so in patients where you want to try the combination, approved now, a little bit higher toxicity, of course, higher cost, but you get a higher response rate and a better progression-free survival.